So, we're going to talk about antibacterial therapy. And I deliberately, we call drugs that we use to treat bacterial infections, we call them antibiotics, which is not really a proper term, because antibiotics generally are any drugs that will treat infections caused by microorganisms. So this is why I call it antibacterial therapy, because we're only talking about the drugs that target bacteria. We're going to talk about antifungals and anti-helminthic and antiviral drugs on a separate occasion when we're going to talk about the corresponding groups of microorganisms. So first, let's just think about, sort of general consideration, the history of antibiotic discovery. Now, I told you before that in general I do not ask you to memorize the numbers. That is true in this case as well. So when I tell you when, please don't memorize that column in the table. But I do want you to understand the rich history of human discovery of antibiotics. The first antibacterial drug that was consciously designed and used was Silvarsin, developed by Paul Ehrlich. This drug was extremely toxic since it contained arsenic, but it could treat syphilis. So a lot of people, when they had to choose between arsenic and syphilis, they chose arsenic, which is, I would do exactly the same. Okay? Now, the first, real, true, safe, relatively safe, synthetic antibiotic came from Germany, as many good and bad things. It was sulfanilamide, or Prontosil. So the story has it that the daughter of the guy with the last name Domack, she was doing embroidery and pricked her finger with a needle. And it turns out that needle had some microorganisms on it, streptococcus. So long story short, she developed necrotizing wound, and there were no treatments at the time to stop it. And again, there's probably a more detailed story, but these three guys worked for a company, I believe it was Bayer. And you know that in Germany, every chemical company, the road from drugs to chemical warfare is short and straight, and that's what they did eventually, but we got to give them props for discovering sulfanilamide. So he brought one of the drugs from one of the chemicals from his work and tried it on his daughter. It was probably had some reasons. It wasn't just, oh, let's just stuff that woman with whatever I have and see what happens. But she was cured. Okay? And they, rightfully so, received a Nobel Prize in Physiology and Medicine. Then there was famous Alexander Fleming, who discovered penicillin, and usually all the credit is given to Fleming, who was a Scottish microbiologist and physician. He was growing a culture of Staphylococcus aureus. He came back from the weekend vacation to the lab and discovered that one of the plates with the culture of Staph aureus had a fungal contamination, and he probably wasn't the first to have this issue, but he was the first to notice that the area around that fungus was absolutely clear of bacteria. He made a logical assumption that fungi, or fungus that was growing there, namely Penicillium notatum, was producing something that was killing bacteria, and he named that penicillin. Okay? It's completely serendipitous discovery, but Fleming identified that Penicillium notatum produces penicillin, but he didn't manage to isolate it. Later, Florey and Chain, and I think Case Nobel Prize in Physiology and Medicine comes from the insulin, Case Western. Anyway, Florey and Chain isolated penicillin, okay, and basically paved the way for its mass production, which was important because in 1940, if you don't remember, Second World War was already raging, especially in Britain, where all these guys were from. So Fleming and Florian Chain, all of them shared Nobel Prize in Physiology and Medicine later. Then there was Dorothy Hodgkin. She was a prominent organic chemist, and she identified the structure, chemical structure of penicillin. Some may think that it's a small feat, but it wasn't, because that enabled chemists to modify penicillin, to tweak this molecule and produce more and more advanced drugs based on the original natural compound. She also received a Nobel Prize. Then there was Zalman Waxman. I call him an epitome of a true American scientist. A Jewish kid born in Odessa in Imperial Russia, who at the age of 16 escaped communist revolution and came to the United States. So he was a Jew growing up in Ukraine, which was a part of Russian Empire. He got his education in the United States, and later discovered a bunch of aminoglycoside antibiotics. Some of them we still use some of them, like neomycin. It's a component of the antibacterial ointment that you can buy at the pharmacy. The biggest achievement of Waxman was to show that there's actually a variety of microorganisms that produce antibiotics, and he was the first to develop drugs that would treat gram-negative infections and could actually be used against tuberculosis, which was a scourge at the time. Now, general concepts. Now, a lot of data that I will present to you are for me to illustrate my point rather than for you to memorize for the exam. Am I making sense? But I want you to understand the general terminology regarding antibiotics. First, the source. Natural, synthetic, or semi-synthetic. Natural antibiotics come from, well, bacteria and fungi. And when you think about antibiotics, hear me out. I want you to think about them as a chemical warfare. Does that make sense, y'all? It's a chemical warfare. It's a microorganism that producing chemical to kill other microorganisms. To be fair, right now, the paradigm shifted, and microbiologists want to think about antibiotics that are naturally produced by bugs, not as the meaning to kill, but as a means to control. Does that make sense? So it's a population balance, so to say. Now, there are some antibiotics that were synthesized in the lab. We call them synthetic. What are semi-synthetic? You take a natural antibiotic and then tweak it to change the spectrum of action or circumvent the resistance, whatever. That's your semi-synthetic. Bactericidal versus bacteriostatic. We already talked about cidal versus static in the context of microbial control, right? But I have a question for you. I'm relatively healthy, not immunocompromised as far as I know. So if I have some kind of mild bacterial infection, does it matter if I get bactericidal or bacteriostatic antibiotic? For me, not really. What if you have a patient who is severely immunocompromised? And I emphasize it, immunocompromised. What type of antibiotic you would rather give them? Cidal or static? Cidal, because there is no help from immune system. You want to eliminate a bacteria. Broad versus narrow spectrum, obvious. Broad spectrum antibiotics treat all kinds of bugs, narrow spectrum only specific groups. Usually they are grouped based on the ability to treat gram-negative or gram-positive infections. Okay? Now, a couple of clinical examples. When you go to a doctor, to an urgent care with strep throat, sore throat, what do they usually prescribe? Amoxicillin. It's a narrow spectrum antibiotic that acts on gram-positive bugs that are the most common cause of strep throat. If a patient has a urinary tract infection, what is prescribed? Cephalexin, which is the third generation cephalosporin. It's a broad spectrum drug because two main causes of urinary tract infections are gram-negative E. coli, number one, and gram-positive Staph aureus, and you want to cover all your bases. Okay, now, broad spectrum antibiotics carry a certain risk of what's called a superinfection when they eliminate non-resistant cells or alter your microbiome, and the microbes that were kept in control by competition aren't kept in control by competition anymore, and you have, like, patients may develop C. diff infection because gut microbiome is impaired. Now, it appears that Mahogany knows her antibiotics, so another question?
Yeah.
Go ahead.
For UTIs, why not just give two narrow spectrum antibiotics, one for gram-positive, one for gram-negative?
Great question. Drug-drug interactions often, and drugs have to be metabolized, so put additional pressure on metabolic active organs like kidneys and liver. You want to minimize it. That's it. You try to use a single drug. Not always. It's not always possible. But Mahogany, do you know what else is prescribed to women when they get UTI in addition to cephalexin? Huh? Okay, but there is another drug. Antifungal. Why? In vagina, yes. Yes, and pretty much everybody carries Candida albicans. Okay, it's a fungus, it's a yeast. And usually it is kept in check, but if vaginal microbiome is altered, it's not anymore. Making sense? And ketoconazole will take care of it. Route of administration is important. Okay, it's logical that, intramuscular is good, intravenous is even better, because the blood concentration of drug goes up very quickly, but it's a bit challenging for someone like me to inject myself IV every time. So often you have to compromise. Usually oral antibiotic treatment is longer. Okay. Synergism between the drugs. What does that mean? Let's say you have two drugs, and that kind of to Sean's question. You have two drugs, and each of them is bacteriostatic, but you combine them, and the combination becomes bactericidal. Example of this will be Bactrim. So where do we get antibiotics? We don't. The last clinical introduction of antibiotic, like real new antibiotic, I think was about 20 years ago. Okay? It's a problem. We failed to discover new types of antibiotics that are suitable for mass production and administration. So we're losing the war. Okay? But for the most part, soil and screening of synthetic compounds. Speaking of soil, really interesting story, kind of, not really related to antibiotics in general, but you're probably familiar with a company called Merck. I don't know about now, but at some point they had a very interesting program for employees. When employees, and again, I'm talking about research branch of the company, okay? When employees went on vacation, they were given a sterile container to collect the soil from wherever they go. Does that make sense? And then they brought that soil back and tried to isolate what they can and screen for new antimicrobial drugs. Everybody in this room, and I will not accept the answer, no, I didn't. Everybody in this room heard about ivermectin. This is exactly how it was discovered. Somebody took a vacation in Japan, brought a sample, it was isolated, tested, and it's a very effective anti-helminthic drug. Okay? Make sense? Now, what does this represent? I think it's a great practice slide. Print it, cover the antibiotics, and start working on the main targets for antibiotics. Now, the targets are pretty logical because you want to target structures that are present in all or almost all bacterial cells, and without which bacterial cell will die. So think about what's going to happen to a cell if you disrupt the cell wall structure. It's going to get lysed. You screw up plasma membrane, that's even worse. There's a uncontrolled transport and potentially lysis. Ribosomes, when you mess around with ribosomes, you can synthesize proteins. You mess around with DNA synthesis or RNA synthesis, well, there's no replication and there's no transcription. And there's a variety of metabolic pathways that you can target. Some of them are common for all bacteria. Some of them are rather unique that can be used as well. And we're going to jump straight into the huge group. I don't want to use the term class before. I need to, called beta-lactams. So, before I start talking, let me go to the table at the bottom and explain what you need to know. Okay? These are 4 classes: penicillins, cephalosporins, monobactams, and carbapenems, which all belong to the beta-lactam group. Am I making sense? All of them act by inhibiting the enzyme called transpeptidase. This is all you need to know. So you need to know the class and the mechanism. Am I clear? Now, to check that you understand, will I ever ask you on the exam about the spectrum of activity? No. Source? No. Specific drugs? No. When I say specific drugs, here's what I mean. I will not ask you a question, what is the mechanism of action for ticarcillin, which is a drug? I can ask you, what is the mechanism of action for penicillins, plural. Ticarcillin is one of them. Okay, that makes sense? Yes? No? No? Okay. Do you acknowledge that here there are 4 classes of antibiotics? Do you acknowledge that within each class you have a bunch of individual drugs, like penicillin, methicillin, amoxicillin, blah, blah, blah? Yes? So the question will never use the term for a specific drug. It will use the term for the class. Am I clear? Okay. And I'll get back to this over and over again. So let's figure out how does antibiotics work. So these are 4 classes, and of course, as usual, you have to memorize all the chemical formulas. Just kidding. What I want you to see in this, I really want you to take a close look at these formulas. Do you see these beta-lactam rings? Yeah? So this is the central structural element. And there's a bunch of chemical bells and whistles that hang off of that beta-lactam ring. Okay? So presence of that beta-lactam ring enables these antibiotics to bind to an enzyme called transpeptidase, or penicillin binding protein. So what does it do? So here on the left, it's on the left is the normal cell wall before antibiotics. Okay? So you have this glycan chains that are connected by peptide linkages. We talked about it in Unit 1, did we? Yeah? When you block the action of transpeptidase enzyme, these links, the peptide links, aren't formed anymore. And the glycan chains, they aren't connected to each other. Am I making sense? So I used to compare this when I was talking about it. Like imagine you're building a raft. You get a bunch of logs and you need to cross-link them in order to make a decent raft. But if you don't, they still get afloat, but if you step on the raft, you're going to fall through. That's what happens to the cell wall. It becomes very loose and eventually cell lyses. Okay? Now, these antibiotics have high selective toxicity. So what does that mean? Selective toxicity implies that antibiotics only affect the bacterial cell but not human cell. Why? All beta-lactams, be it carbapenems or penicillins, why do they target overwhelmingly bacterial cells but have very little effect on human cells? Which bacterial structure do they alter?
Cell wall.
Just cell wall. Just cell wall. Bacterial cells, do they have cell wall? Many of them, almost all of them do. Human cells? There you go. Human cells don't have cell wall, so this is why these antibiotics have high selective toxicity is good. It means that they're selective, you know? Now, what about this table? So those individual drugs, I'm not going to ask you to distinguish between them. I just want you to acknowledge a few things. So these are drugs. And these, like that line, the R group, that refers to whatever is hanging over here. You know, the R group, right? Right here. So you can see that different drugs from the penicillin class, they have different R groups. Right? And when you start looking at the characteristics, different spectrum of activity, different route of administration, they may overcome the resistance. So that's what these modifications are for. Now, beta-lactams have a very interesting mechanism of resistance. They produce, that was a poor choice of wording. Bacteria develop a very interesting mechanism of resistance against beta-lactams that involves enzymes. So there's an enzyme called beta-lactamase. There are different types of beta-lactamases. These beta-lactamases break down this ring, the beta-lactam ring that you see over here. Now, if this beta-lactam ring is broken, can antibiotic work? There you go. It's a resistance. So what are we supposed to do about that? Well, we have another cool drug that is called clavulanic acid or clavulinate. Some of you may have heard about this drug. So how is this working? Now, check it out. So you have amino acids, right, that are used by transpeptidase to form peptide links. This is the normal process. Hear me out. This is the normal process in bacteria, okay? When we employ penicillin, I'm going to use penicillin, but that will be true for other 4 classes, monobactams, carbapenems, or cephalosporins. Penicillin blocks transpeptidase, right? But then bacteria produce beta-lactamase called penicillinase, which destroys or chemically alters penicillin. Now, penicillinase is an enzyme. Can you inhibit an enzyme? So, clavulonic acid inhibits penicillinase. Penicillin remains intact and bacteria killed. I'm going to say the word, and I want to see your facial reactions, like if you've heard that word. Augmentin. Yeah? That's the mix of amoxicillin and clavulonic acid. Specifically used to treat potentially penicillin-resistant gram-positive microorganisms. All good? Now, to other classes that mess up the bacterial cell wall are glyco and polypeptides. So the class of glycopeptides includes pretty much the only drug, vancomycin. So vancomycin prevents, hear me out, both the formation of peptide linkages, you can see it here, but also it can prevent the formation of glycan chains themselves. So cell wall just not being synthesized. Am I making sense? And finally, bacitracin, which blocks the transport of the building blocks here. There's a building blocks. Peptidoglycan subunits. They are not transported outside of the membrane. Okay. And cell wall cannot be built. Now, the analogy that I use usually deals with the walls. If you need to build a brick wall, you need bricks, and you need mortar, and you need a truck to deliver all those materials to the building site. Agreed? So in this analogy, the bricks are glycans. The mortar are the linkages. Beta-lactams make mortar obsolete, so now you just have a pile of bricks. Rows of bricks. Vancomycin, one of glycopeptides, both prevents the linkage, and the bricks are in all different, arrangements, so in wrong arrangements, just pile of bricks instead of a wall. And then bacitracin stops the truck, so nothing gets delivered to the construction site. Clear? Okay, so I would say that probably 40% of antibiotics that humans use are inhibitors of cell wall synthesis. Another 40 say again? Inhibiting cell wall synthesis. The mechanisms are slightly different, but the target is the cell wall. Now, what about protein synthesis, right? cells cannot exist without it. Well, bacterial ribosomes, 70S ribosomes, are structurally different from eukaryotic, in our case, specifically human ribosomes. Do you follow my train of thought? You can design a drug that will bind and block the function of bacterial ribosomes, but not human. So they also exhibit high specific toxicity. Okay? So another 40%. Now, conceptually, there are two large groups of protein synthesis inhibitors. A group that binds to 50S subunit of a ribosome and prevents the formation of polypeptide itself. And the group that binds to 30S subunit and messes around with the transport RNA carrying amino acids into the ribosome. So we're going to start with the 30S subunit inhibitors. The first group is aminoglycosides. Now, I don't know if you sort of ran into those antibiotics, but I like to keep you informed. Next time you use antibiotic cream or ointment, take a look at the composition. There will be neomycin, broad-spectrum antibiotic. There will be bacitracin, broad-spectrum antibiotic. And there will be a third antibiotic, which identity I will reveal a little bit later. So I like to maintain some kind of a suspense. Now, if you find these pictures of mechanisms funny, you might as well just stand up and leave the class, because I tried to make them quality, but the software called BioRender costs like $500 a year, and I wasn't ready to pay for subscription, so all of it has been done in PowerPoint, and I know that these images suck, but that's the best I could do. So aminoglycosides here, they bind into the A site of a ribosome, and they ensure that the tRNA that comes in is wrong. That make sense? So let's say your protein is supposed to be glycine, alanine, serine. Instead it goes glycine, alanine, aspartic acid. Completely different, okay? So, altered sequence. Sometimes they can pretend that it's a stop codon, and then the protein will be short. So cell, and here's the ingenuity of this antibiotics. They don't kill the cell. Cell still makes proteins. This protein is just shitty, and they don't work. So cell gets overwhelmed with shitty proteins and runs out of resources. Okay? Now, what about tetracyclines? Tetracyclines are very old. As far as I remember, tetracycline was introduced first in the clinical practice in 1948. That's a long time ago, almost, 80 years. Okay? Still kicking. It's a broad-spectrum antibiotic that works by simply blocking tRNA from entering the A site. Okay? Now, I mentioned before, and I want to emphasize that. Focus on the class and the mechanism. Ignore individual drugs or spectrum or source. Now, what about 50S? Ribosomal subunit and its inhibitors. So there are three different classes of drugs: macrolides, lincosamides, and streptogramins. these three all prevent the polypeptide from being released from ribosome, so it stays there and there's no protein produced. Now, this statement here that they broad spectrum is not entirely correct. Erythromycin is not. Azithromycin, what is the commercial name? Anyone knows? There's a letter Z. Huh? Z-Pack, yeah. Azithromycin is a broad spectrum, yes, that is true. Okay, all good? Everybody follow me? This so mechanism is blocking the release of polypeptide chain. Chloramphenicol. This is a synthetic antibiotic. When we talked about translation, you may remember we did this, like there's a transfer of an amino acid, connection between the amino acid, incoming amino acid, and the growing polypeptide chain, right? Chloramphenicol blocks that. So polypeptide chain cannot get elongated. And then a group in itself, oxazolidinones. The most famous member of that class is linezolid. It prevents the formation of the ribosome altogether. Okay, make sense? It blocks the initiation complex formation. This drug is used almost exclusively to treat Mycobacterium tuberculosis, and we will discover why. So far, good? Okay. These are my favorite antibiotics, but from clinical perspective, they suck. Let me explain why. Polymyxins. They disrupt outer membrane of gram-negative microorganisms, and gram-negative organisms die. Sounds good. There's only one problem. Membrane is a rather conserved structure, so the membrane composition in human cells and in bacterial cells is fairly similar. So what do you think side effects are going to be? Pretty toxic. So polymyxin B, which is the third component, in addition to neomycin, bacitracin, third component of the antibiotic cream, is so toxic that it is used only topical. It's fine on the skin. It's not used intramuscularly or orally or intravenously because it's horrible. I call it his younger brother, polymyxin colistin. I want you to look at what it does. Okay? Look at this statement. Bowel decontamination. It's a nuke. You have about 3 pounds of bacteria in your bowel. Colistin can wipe them all. That's bad. Like, it is really an effective antibiotic against gram-negatives, right? There's only one problem. It's nephrotoxic. So I listened to a case presentation of a woman who had, ironically, a kidney infection with Enterobacteriaceae. I think it was E. coli or Klebsiella, I don't remember. The point is, it was a multiple drug resistant, MDR, multiple drug resistant gram-negative infection. So doctors ran out of options, and bacteria kept ravaging her kidneys, so doctors said, to hell with it, we're going to give her colistin. Is it going to kill bacteria? Yes. Is it going to ruin the kidneys? Also, yes, but we can deal with kidneys later. At least she will survive. Because if, not treating, she's going to die. And yeah, her kidney function, declined, but at least she didn't die of infection. This is the last resort. They're not commonly used. Only colistin is used systemically, and side effects are horrible because membranes are so similar. Am I making sense? Then we have lipopeptides, which form this nice little channels, pores, in the bacterial membrane, and ions are not distributed as they're supposed to. Membrane potential of the cell is lost, and also pretty toxic, but they can treat, interestingly enough, gram-positive infections. Nucleic acid synthesis. So we have 3 classes here: rifamycins, fluoroquinolones, and nitroimidazoles. So rifamycins. Anyone heard, met in your line of work the drug called rifampin? Yeah? Which patients? What did they have? Do you know? Probably tuberculosis. So rifampin, the representative of rifamycins, it's not effective only against Mycobacterium tuberculosis, but it is used very actively to treat that specific infection. And again, I'm building a suspense to explain at the end why I always mention Mycobacterium tuberculosis. The mechanism is that it blocks RNA polymerase. So no transcription, no protein synthesis, cell dies. Then we have fluoroquinolones. 100% you've heard those names. Ciprofloxacin. Yeah, Cipro. Right? Fantastic antibiotic. Really good. Broad spectrum, very effective. Blocks DNA gyrase. So when DNA gyrase, shown here, is inhibited, DNA replication cannot proceed. Sounds good? One problem. Side effects. Now, side effects will never be on the exam, like specific side effects. I want you to understand the concept of high specific toxicity. That makes sense? Like I can ask you, why inhibitors of cell wall have high specific toxicity? And you tell me because human cells do not have cell wall, while bacterial cells do. Clear? But not the specific manifestations. But I will tell you specific manifestations for Cipro. Does anyone know, by the way? It's a lifelong problem. They make connective tissues very fragile, which means tendon and ligament and muscle tears. And that's forever. Like you can receive ciprofloxacin today, you can develop tears for the rest of your life. Again, it's not like you are like super fragile and if you like pick up the pen, it immediately tear. But yeah, you should be careful about, physical strain that you put on your muscles. Okay? And then nitroimidazoles, which I absolutely adore for, like, they are the salt of the earth in antibiotics. A couple of reasons. They're very indiscriminate. And the mechanism, we don't know the mechanism, by the way. Have you heard about flagell? Yeah? Metronidazole, that's one of them. We don't know how it works. We do know that it messes up DNA. It was shown to cause breaks, but we really did not pinpoint the exact mechanism of action. Another weird thing about flagell, I was talking about, gram positives, gram negatives, right? Flagell, one of nitroimidazoles, blocks anything anaerobic, including protozoa. So here's my question. Gut. Is it aerobic or anaerobic? Very anaerobic. So anything that causes bad gut infection is probably anaerobic. And in some cases, especially if it's not humans, like if you have a dog and they have a really, really bad diarrhea, like mucousy, maybe even bloody, physician will not even test it. They will just prescribe Flagyl. It will wipe out anaerobes, and you're going to be on your way. Making sense? But we're nearing the end of the story, which I find one of the most fascinating chapters of metabolic pathways. There are some metabolic pathways that are essential for bacterial cells, okay? One of them is the synthesis of folic acid. Okay? So the folic acid synthesis is essential for the future synthesis of nucleotides, which comprise RNA and DNA. Okay? So, since it's not a chemistry class, I use it for illustrative purposes. So it starts with pyraminobenzoic acid, which is converted through multiple steps, blah, 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 into tetrahydrofolic acid and then nucleotides. Does that make sense? So folic acid synthesis is essential for nucleotides. Am I clear? So those sulfanilamide, it's a class of sulfonamides. Sulfonamides are structurally similar to pyraminobenzoic acid, which you can see, That makes sense? So this is your PABA. This is the drug. There's structural similarity. So the drug, sulfonamide, blocks the first enzyme in the pathway. It competitively inhibits the first enzyme. Do you need to know the names of the specific enzymes? No. And then there is a drug called trimethoprim here, which acts as the competitive inhibitor of another enzyme. If you use each drug separately, they are bacteriostatic. When you combine them, they become bactericidal, the classic example of synergism. And the combination, now it's, I don't know, maybe you encountered it somewhere, the acronym TMP, SMX. TMP stands for trimethoprim, SMX stands for sulfamethoxazole. And the combination is called Bactrim. Okay? It's a good combination, broad spectrum. Now, I'm going to ask you a few questions. When you block nucleotide synthesis and there are no nucleotides, which processes are affected? Cellular processes. Synthesis of which molecules? Transcription and? Nope. Translation secondary, yes, but so RNA synthesis and what else? What else? DNA synthesis. DNA. Hear me out. Proteins, yes, but not directly, because RNA is not synthesized. So if DNA cannot be synthesized, can a cell divide? No. Other cells, human cells, that divide frequently, not cancer, just frequently. That's ANP2 material, folks. Cells that have to be replaced over and over again. Yes? Huh? Depends on epithelium, but you're right. But which epithelial cell, like which system has pretty aggressive environment that requires frequent replenishment? Skin, yeah, but it's layered, so it's slower. Yeah, digestive, right? It is one of the main side effects of Bactrim. Huh? Can't hear you. No, not that. I mean, it probably can do, but it's like, that's outrageous. No, like, you have a kid, you give him Bactrim, what are they going to complain about? Yeah, tummy ache. It gets very bad, like, it's very painful. We went through this. one of our kids had he was prescribed Bactrim, and then I brought him to emergency. So it was that bad. Like he was rolling on the floor crying. And then eventually it subsided, and they said just stop using it. Okay? Because he was fine already. Then we have a really cool antibiotic called isoniazid. It's it's nalidixic acid, but it's in a class of itself. So what it inhibits is the synthesis of mycolic acid. Remember Mycobacterium tuberculosis? Right? They have mycolic acid on the outside, which makes them kind of Iron Man-ish of bacteria. Well, they aren't anymore if they don't have mycolic acid, and they become sensitive to phagocytosis, for example. Clear? Now, will this antibiotic that specifically inhibits the synthesis of mycolic acid, will it be effective against bacteria that do not produce mycolic acid? No. So it is a very, very narrow spectrum antibiotic that targets specifically Mycobacterium. And then we have fluoroquinolones. These guys inhibit ATP synthesis, specifically ATP synthase. Remember that barrel-looking transmembrane protein in bacterial membrane that churns out ATP. So here's my question. ATP synthesis, oxidative respiration, aerobic respiration. The process, is it similar between bacteria and humans? Very much so. Side effects. Liver and heart. So hepatotoxicity and arrhythmias. And I want to play a little bit of a physiology game with you folks. Why it's toxic for liver? It's all about respiration. What is the function of liver? Detox, metabolism, right? Yeah? Does it require energy? That's your answer. Now, what does that mean if somebody has an arrhythmia? Cardiac arrhythmia, huh? Wait, not all together at the same time. Hold on. Okay. Not just in the, tachycardia is kind of super fast, but it's still rhythmical. But arrhythmia means that there's no rhythm. Did someone say fibrillation? No, yeah? What did you say? But what would you present arrhythmia as? You said fibrillation. Atrial fibrillation. Sure, yeah. Why? Why, if there is not enough ATP in the heart, it goes bananas? That's not an easy question. It's a question for ANP2 nerds.
Is it because it messes with your sodium potassium pump? And then
Not quite. Contractions are rhythmical. I don't know. What do you think?
Because your heart is an electrical pump, so if you don't have the
Energy for pumping? Oh, you have plenty of energy.
for pumping, but also it's an electrical pump, so it's not, there's not enough energy for it.
Electrical ID is correct.
does it somehow like add ATP, making it want to beat more than what it actually can?
Okay. So it's a hard question, and I want to follow through on this with you all. So let's start with Ladona's idea that it's all about electricity, right? Your heart contracts because electricity runs through the heart. Okay? Now, you don't have a designated neuron that goes to every cardiac muscle cell, right? You have this conducting system, a SA node, AV node, Purkinje fibers, and so on. But somehow electrical impulse spreads through the entire heart. Like when SA node is depolarized, the electrical impulse goes through the entire atria. What connects individual cardiomyocytes, individual cells? It's some type of a junction. Gap junction. So, what keeps them, do you need energy to keep them open? And if you run low on ATP, those gap junctions close. And cells become asynchronous. They don't know what the other cell is doing. That makes sense? So it's all explainable from the physiological standpoint. Now, this table is for your review. I know you can read it. It's sort of a summary. I'm not going to read it for you. Use it as a summary. And now we jump to antibiotic. Again, let me give you an example how the question may look like. Which of the following antibiotics inhibits protein synthesis? Answers. I'll give you the answers. Only classes: cephalosporins, fluoroquinolones, polymyxins, aminoglycosides. Does that make sense? Or, inversely, what is the mechanism of action for basic tracing? Inhibition of cell wall synthesis. Okay? I will ask you in some form about the idea of high specific toxicity and low side effects versus low specific toxicity and high side effects. Clear? And I'm not asking you to memorize which side effects. But if I ask you, can you explain, basically, why cell wall synthesis inhibitors have high specific toxicity and relatively low side effects? Because human cells do not have cell wall. Or why the same is true for protein synthesis inhibitors? Because bacterial ribosomes and human ribosomes are very structurally different. And why polymyxins are so terrible in terms of side effects? Because the membranes in bacterial and human cells are pretty similar. Does that idea make sense? Okay. Now, mechanisms of resistance. 7. Question will look like match the term, the mechanism, with its description. So let's get to this. Remember our conversation about beta-lactamases that destroy that beta-lactam ring in the drug. Can we say that this enzyme modifies the drug? Yes? Yes. This is drug modification. Okay? That makes sense? Now, can bacterial cells somehow block the entrance of a drug into the cell? Yeah, why not? They will decrease the number of certain like porins, transport proteins. So that's your prevention of cellular uptake. Can they pump out the drug? Sure. Why not? So we've got efflux pumps. Now the target modification is a little bit tricky, and I will try my best, I never did that before, to illustrate. Okay, so this is the binding site. Okay, simpler. This is the target. This is some protein in the bacteria, okay? This is the drug. Can drug bind to this target effectively? Yes. Now, what bacteria are going to do, they're going to change the target. Can the drug bind now? Have you heard about MRSA? Probably. Well, it's a rhetorical question. Methicillin resistance is because the target transpeptidase is altered. So penicillins cannot bind to it anymore. Are we good so far? Well, good. Let's continue. So we got target modification. Now, target overproduction. So, listen. Imagine that I'm a drug and you're all my targets. Okay, potential targets. Let's say I enter the cell and I only see Sean. Can I block him? Yeah. Now I enter the cell and I see all of you. Can I still block Sean? I can. I can't block everybody else. So it doesn't really matter. Okay, make sense? Cell just overproduces the target and we can't get enough antibiotics in. Enzymatic bypass, so they have another metabolic pathway. Let's say you want to inhibit folic acid synthesis. Cell has some other pathway that circumvents the inhibition and still it's produced, the folic acid. Okay. Finally, target mimicry. So it's actually a pretty interesting story. So imagine you have some kind of a target. That's an actual protein and the drug. So what cell will do, it will produce something that looks like target. So the drug will bind to that useless molecule and will spare the actual enzyme. Go ahead.
What's the difference between target mimicry and then target overproduction?
Good question. Because in case of target overproduction, the bacteria would make a gazillion copies of this, and that's it. Instead, bacteria makes a gazillion copies of much smaller molecules, so it uses less resources. Okay? Mini cell formation will not be on the exam. It's nothing specific, but it's a weird mechanism. So please memorize all the information on that slide, including numbers. Okay, now seriously, what you need to know here. Listen. This is the acronym. Okay? Within that acronym, you're going to find a specific microorganism or group of microorganisms. And you need to know what these microorganisms are resistant to. For instance, that acronym CRE. Which microorganisms are we talking about? Enterobacteriaceae, it's a big group. What are they resistant to? Carbapenems. There will be no questions about mechanisms and clinical considerations. Okay? So the question may look like versa. Which bacteria are we talking about? Staph aureus. What is it resistant to? Vancomycin. Okay? Now, I deliberately am going to skip Mycobacterium tuberculosis for now, because I want to talk about it a bit later. And I'm going to get to the testing of the efficacy of drugs. So the classic method is Kirby-Bauer disk diffusion test. So you've got this disks that are infused with antibiotics. When you place them on microbial culture on the plate, antibiotic starts leaching into the agar, killing bacteria. So far, does that make sense to everybody? As antibiotic diffuses away from the disc, its concentration in agar decreases. So basically, this is the disc, and that's the concentration graph. Like, eventually it reaches 0. Now, the more effective the antibiotic is, or the more sensitive the bacteria are, lower and lower concentrations of the drug will be able to kill and block its growth, right? So this inhibition zone, its diameter shows you the sensitivity. The greater the diameter, the greater the sensitivity. And this is actually a great example. This is Staph aureus, which is bad but pretty sensitive. And this is Pseudomonas aeruginosa, arguably the most antibiotic-resistant bacteria in the world. I mean, among those that we know. Now, this method is real good. There's only one problem. You test fixed concentrations of antibiotic. So maybe you want to see what is the smallest concentration that will inhibit the growth of microorganisms. For this, you need a dilution method. So when you look at this image, these tubes have different concentrations of an antibiotic. Am I making sense? The first 3 keep the medium clear, meaning that they effectively inhibit bacterial growth. Last 2 fail to do that. So this 8 micrograms per mil is minimal inhibitory concentration, or MIC. You can do the same using 96 well plate. It's a plastic plate, and you just change concentrate, make serial dilutions. You have different antibiotics, and then you can you don't really have to look. You can quantitatively measure. Remember turbidimetry we talked about? You can measure how cloudy the medium is in each well, and if it's not cloudy at all, good. Good.
Okay, so is this measuring the effectiveness of the antibiotic, or how sensitive the bacteria is to said antibiotic?
What is the difference?
Well, like if it's, I guess, well, yeah, I guess if it's working, it's working. Right.
So you can look, depending on what you're looking at. Let's say, hear me out. Actually, it's a great question. It is a great question. Let's say you have a patient with some unusual bacterial infection, like Acinetobacter baumannii. Okay? So you isolate that Acinetobacter, grow it, then make this array of different antibiotics in different dilutions, load them all with Acinetobacter, and see which antibiotics will be more effective at killing it. So in this case, you're measuring the effectiveness of antibiotic, I would say. Now, you discovered a new antibiotic. You want to see how it works against the spectrum of bacteria, so you make a series of, I don't know, Staphylococcus, Streptococcus, Bacillus, E. coli, you name it, and then you apply the same antibiotic to all the bacteria and say, okay, how effective it is, or how sensitive the different bacteria are. Does that make sense? It depends on what you want to make an emphasis on. Okay, there's a combination of dilution test and basically Kirby-Bauer, the E-strips. So there is a standard, like the inhibition zone has to have a diameter of 25 millimeters. So look, hypothetically, let's say it's at 64, it's 25 millimeters, the inhibition zone size. So that's the minimal inhibitory concentration, and you just keep moving. Here, just understand like which methods allow you to check for MIC and match the method and description. Now, therapeutic index. So in this graph, you can see two parameters that characterize a drug. One of them is median effective dose, meaning that this specific dose of a drug will have an effect, a desired effect, in 50% of an experimental group, or treated group, right? So if 100 people, you give them the dose, 50 of them are cured. Clear? Then there is a toxic dose. So this is the dose at which 50% of people in an experimental group will have toxic effects. Okay? So therapeutic index is the ratio. You divide toxic dose by the effective dose. Do you want the therapeutic index to be high or low? Hear me out. Do you want the toxic dose to be high? Yes, because it means high dose. It means that you have to give a lot of drug to poison a patient. Am I making sense? An effective dose, do you want it to be high or low? Low, so you only need a small amount of drug to produce a desired effect. And if you look at this fraction of this ratio, right? If you have a huge enumerator on top, which is toxic dose, okay? So what I'm saying is, if this is super high and this is super low, then therapeutic index will be very high, and it's good. Yeah, obviously, not all the drugs can, I remember there was a drug, experimental, that had ultimate lowest therapeutic index of 1. It was some veterinary drug, I don't remember. It was treating horses for some helmintic infestations. They treated a horse, helminths came out, next day the horse died. Because of the drug. It's a shitty drug, So the idea is that if you have high therapeutic index, if the patient doesn't respond to treatment, you can increase the dose without harming the patient. I will ask you to calculate a therapeutic index. You can use the calculator, don't worry. I will provide the data. Yes. And compare drugs. You need to know that higher is better. Are we clear? So let's look at this delight known as Mycobacterium tuberculosis. But before we do that, you may have noticed that I have this Mycobacterium avium, which comes from birds. Has no clinical significance for people who are immunocompetent. If your immunity is fine, you're not going to get infected or sick. Clear? It does affect people with AIDS pretty badly, or any other immunocompromising condition. So we're done with, and symptoms, basically tuberculosis, but in immunocompromised people. We're done with this. Let's move on to Mycobacterium. Key qualities. Grows slowly. Do you think it's an advantage or disadvantage for bacteria? Slow growth. It's an advantage. Hear me out. If you have bacteria that reproduces fast, all antibiotics that we considered so far, many of them at least, prevent bacteria from dividing ultimately. And if it divides fast, you need to maintain the treatment for like 2 weeks, and you're good. If it grows slowly, you have to keep antibiotic going for months, which is a problem because side effects, and cost. I can plug my own personal experience. One of the kids, and he had staphylococcal infection, which is fast growing, but it was smoldering. He had osteomyelitis when he was a kid. Smoldering staphylococcal infection of the bone. He had to take antibiotics for 6 months, orally, 3 times a day. And we had a really good we had really good insurance. It was clindamycin. Our copay was $50. I mean, I'm not bitching, but it is the most expensive drug that I ever paid for. Like prescription drug, not in the hospital. Okay? Because it was way over 50, but I only paid copay. Okay? Because the alternative was IV and we couldn't do that at the time. Another important thing, resistant to drying. So if somebody who has tuberculosis sneezes or coughs on the doorknob and it dries out, most bugs will die when they dry out, not this one. And it's aerobic, which means it will grow only in the environment with oxygen, which becomes important later. So yes, mycolic acid. It's protected against phagocytosis, and in fact it infects macrophages and lives in them. Okay? And I'm going to skip the mechanisms and focus on this. Granulomas. So what happens? Hear me out. Imagine you have a macrophage and it's infected with Mycobacteria, right? Your immune system will recognize that this macrophage is no good and will try to kill it. The problem is that when it's killing it, there's a lot of collateral damage to the surrounding tissues from the actions of cytotoxic lymphocytes and CD4 T cells. So eventually, the granuloma where there's macrophages hanging out, it starts forming that core of necrotic tissue. So your body senses that, says, to hell with it, and puts it in a capsule. The walls of the capsule are made out of fibrin, which blocks the spread of that bug. So it hangs out in that granuloma. It is latent. It is asymptomatic. In fact, most people who are infected are absolutely asymptomatic. Does that make sense? When people become immunosuppressed for various reasons, bacteria reactivates, grows to the degree that it escapes from granuloma, okay? Here, it escapes from granuloma and spreads. Now, okay, perfect. So, what is the clinical picture? First of all, it's very transmissible, but only small proportion of people who are actually infected develop clinical tuberculosis. The very conservative estimate puts 1/3 of world population in the category of people who are infected. Does that make sense? So what do you need for transmission? Crowds, poor sanitation and ventilation. So right now, tuberculosis is the disease of people who are imprisoned, because usually those places are crowded and ventilation may not be optimal. In the United States, people who work in prisons and work with incarcerated populations the closer you work with incarcerated folks, the stricter the requirements for a TB test. Okay, does that make sense? Like, you have oh, you've got that result, that's already suspicious. Okay? In Russia, I have this pretty sad joke. If you go to a jail or a prison, and then let's say in 6 months you're released, tuberculosis is the parting gift. Pretty much every person who gets, I know a case of a person who spent 2 months, who's pretty famous in Russia, came out with tuberculosis. Okay? It's almost guaranteed. So, one more question about transmission, actually. So, when you read fiction from early 19th century, very few mentions of tuberculosis. It's not, people die of, I don't know, heart attack, or they kill themselves, or they drive, whatever. But not tuberculosis. Then, when you start reading books about late 19th, early 20th century, everybody has tuberculosis, especially in the United States. Why? What happens in the United States at the end of 19th century? Economically, huh? Not just immigration. Economically, what happens? Great Depression is 1929, then before that. Industrial Revolution, which moves people to where? And they start living in apartments in the crowded conditions with poor ventilation. That's it. It makes sense? And it really is associated with every country you look at. Once you go from agricultural to more industrialized society and people start crowding up, tuberculosis will get there. So primary, when you get infected, mild fever, and then most likely you're not going to have any symptoms. Okay? My mom had extrapulmonary tuberculosis, infection of the lymph node, and she never had any other symptoms. It was just granuloma. And they decided we're just going to surgically remove it. Okay? Now, pulmonary chronic tuberculosis. I'm going to read it for you, and I'm going to ask you, does it remind you of something? Coughing, greenish sputum, bloody sputum, fatigue, night sweats, low-grade fever, chest tightness, breathing problems. I can bet all of you went through some kind of a questionnaire answering if you have any of those. New patient. When you become a new patient of primary care provider, those are the questions on the screening list. They're screening for tuberculosis. That's it. Okay? If you answer yes, they're going to test you. Now, we're going to get to diagnosis. So here you can see, lung obstruction and lung obstruction. So that's bottom is very severe tuberculosis. Sometimes tuberculosis leaks out, quote unquote, and gets in other tissues. It's called extrapulmonary or miliary tuberculosis. It's bad. Lymph nodes, kidneys, bones, meninges. So when our son was diagnosed with osteomyelitis, they did biopsy and tested for bacteria, what bacteria it was. And I never saw such a relief on the doctor's face. Because he was in a very bad mood, and he opens up the results and it says Staph aureus. He's like, thank God it's not TB. Because it's completely different treatment. Okay? My great uncle died of bone tuberculosis before any treatments were available, and I cannot imagine what it's like. Like, you are an adult, you know what you have, you know that you're going to die, and you have like 5 years or whatever, and there's nothing you can do about it. Okay? How do you diagnose it? Let's say now, let's say you have a suspicion that you have, or your physician thinks that you may have tuberculosis. What's going to be the diagnostic test now? It's going to be blood. They're going to do blood draw, and they're going to send it to the lab, and that, I don't remember, I think they test for antigens. So they test if you actually have bacteria or DNA, like you actually have. I will explain why. A separate occasion that will not be on the record. Okay? Chest X-ray to see symptomatic pulmonary tuberculosis, or staining the sputum, Zell-Nielsen stain. I mean, if you cough up blood, that's a pretty telling thing, you know. But you can test, there's a staining, like a microscope is staining, they can stain and see bacteria. It's similar to carbylfuchsin staining, the acid-fast staining, but it's specifically designed for sputum, not for the pure sample. Prevention, public health. Vaccine is not great. It's BCG vaccine, which is killed bacteria. It's not used in the United States because the rates of tuberculosis are not high, and it's not terribly effective. There is another reason, which I will explain a bit later. It's used almost everywhere else in the world to reduce the frequency of tuberculosis, and particularly extrapulmonary tuberculosis in kids. Like I was vaccinated, BCG. Okay? Now, this is, I love epidemiology. This is the distribution of tuberculosis in the world. So you can see that the US is low. Then, and listen, like what I love about epidemiology, like you can ask, what's going on in certain country? So this country called Mongolia, it was mostly agricultural, so herders, roaming lifestyle. They have a shitload of like things to mine, you know. So it starts getting industrialized. They transition from I'm blanking on the word, from agricultural society to industrial society. That's the answer. Now you may say, what about China? China got industrialized many years ago and was one of the leaders in the world in terms of tuberculosis, but they got it under control because of the public health measures. India still contributes quite a lot, okay? And one of the issues is that tuberculosis is the disease of poor people, and many poor people cannot afford proper treatment, which may take up to a year. So instead, they opt to go to like a low-level healthcare provider, like basically a local nurse, and they will get a prescription for 2 months of kanamycin, which will reduce the symptoms, but also will drive the resistance. And we have an emergence of totally drug-resistant tuberculosis, which, by the way, I want to make a point. When you read about totally drug-resistant, it's not an Incredible Hulk. It's not a bacteria that just impervious to anything. It just means that conventional treatments with the conventional doses don't work. You have to combine, you have to increase the dose, which is not great for a patient. Okay? What about Southeast Asia? What's going on there? Have you heard about Asian tigers?
Yes.
The category of countries like Indonesia, Malaysia, Singapore, Thailand, that's what we're looking at here. So Thailand, Myanmar, like this, Papua New Guinea, Indonesia, and so on and so forth. What's going on in sub-Saharan Africa? One word. No, it's not industrialization. It's poverty. And population growth. Okay, because some countries are relatively small, but the number of people that live there, holy shit. Okay? Like Nigeria is not a huge country, but it has what? Like almost 200 million people or something like that? There is another reason why tuberculosis is rampant in sub-Saharan Africa. Huh? 4 letters. It's an acronym. AIDS. When you look at statistics of the worldwide deaths from infectious disease causes, tuberculosis, I believe, is number 1. Well, during COVID it wasn't, but we're not talking about that time, okay? Number 2 was HIV. And they had a special subcategory there, people who had both. So if your immune system is immunocompromised, like if somebody gets infected with HIV and they're poor and they can't afford treatment, they inevitably develop AIDS, which suppresses their immune system, which makes tuberculosis that they may have had asymptomatic becoming fulminant, and it kills them. So the question, what killed them? It's hard to say, you know? Does that make sense? And I listened to a case presentation of a guy who probably was poor, I don't know. Actual case in the US, I don't remember which hospital. He had AIDS, and he had extrapulmonary tuberculosis. Say again? Oh, I don't know. It was 2 physicians, they have a podcast, and they were just talking about that case. What do you think they started curing? He was cured. But what do you think they started curing first? Huh? TB, yeah. Because TB could kill him pretty quickly. So they pumped him full of antibiotics, got TB under control. They gave him antiretrovirals, got his immunity back, and basically just pumping the guy with the drugs, and TB was gone, and his HIV infection was under control. So as long as he would take his antiretrovirals, he was good. Does that make sense? Okay, good.